Welcome, everybody. It's a great honor for me to introduce Professor Peter Schwartz. I'm going to try to be brief because his short CV is like 10 pages long, so you can imagine his real CV. I've had the pleasure of knowing Professor Schwartz for many years, and he's a great friend, and he's done a lot of stuff. But I'll just start by his brief introduction. So he graduated from medicine at the University of Milan back in 1967, 1973. He became a specialist in cardiology and is currently the director of the Center for Cardiac Arrhythmias of Genetic Origin and the Cardiovascular Genetics Laboratory at the IstitutoAuxologicoItaliano in Milan, Italy. He's also an extraordinary professor in internal medicine at the University of Stellenbosch and an honorary professor in the Department of Medicine and member of the board of the Hatter Institute for Cardiovascular Research in Africa of the University of Cape Town in South Africa. Dr. Schwartz has many accolades. He's published over 1,500 papers, 600 in PubMed that have been peer reviewed. And he's done a lot of research in many areas. He was the professor and chairman of cardiology and director of the School for the Board in Cardiology, Department of Molecular Medicine at the University of Pavia, and the chief of laboratories for research in cardiology at the Fondazione IRCCS at the Policlinico San Matteo in Pavia, Italy. He's also past president of the Italian Society of Cardiology, chairman of the Committee for the European Affairs of Healthcare Resources, and many other things. He was one of the first proponents of a new antiarrhythmic classification way back then called the Sicilian Gambit. I've known Dr. Schwartz, Professor Schwartz, for many years. Many of you may not know, but one of my first stints in medicine was when I was a medical student back in Colombia. And I was actually doing some vagal stimulation with some biomedical engineers in the 1970s. So what caught my eye back then were some of the initial papers that Professor Schwartz did. And the animal model that he developed with Billman and Stone was a fascinating model of myocardial infarction, where he actually showed the first ideas on sympathetic balance in how vagal stimulation could actually prevent VF in these animals. This was quite fascinating. I then had the opportunity to train with Dr. Dwayne Eckberg in Richmond, and we brought Donatella Cerratti, who did one of the first and few single vagal fiber recordings in a beautiful paper published in Circulation Research in 1991. It would take me forever to just go over all of his accolades, but he's been the American Heart Association invited lecturer for the Paul Dudley White International Lecture, and he's done a million other things. And as I mentioned, there's three important areas. He's always been concentrated in sudden cardiac death, but he spent over 50 years in the long QT syndrome, and he's going to give us a beautiful lecture on this, sudden cardiac death in general, autonomic reflexes. He's a true bench to bedside scientist and translational scientist. His experimental model in the dog, he then took it to did the ATRAMI study that has actually served us for the REFINE trial also. So it is really an honor to have Professor Schwartz lecture us today. So Peter, I'm gonna let you take it over now.
Thank you, Carlos. It's a pleasure to see you at distance, and thank you for the kind words and the many names that resonate a lot with me. And good morning to all of you. I was supposed to be in Calgary in person, but this little virus has caused some problems, and here we are. The title of my lecture today is already a reflection of the fact that during the last 30 years or so, it has become rather evident that a number of conditions associated with sudden cardiac death indicate the presence of a genetic predisposition. And probably of all the diseases of genetic origin and cardiac arrhythmias, the long QT syndrome is the one probably best studied and is the best example. It's just by chance that, as Carlos has just indicated, is also the one on which I spent most of my scientific life. But here we go, and what I've planned to do today is, given the fact that there is always in the audience someone not very familiar with long QT syndrome, is to take you through some of the key features first, Then we'll go through therapy and coming to the most advanced and ongoing research areas. I don't want to simply tell you where we are now or show you where we are now. What I really wish is to show you how we get where we are. So it's a long way to Tipperary, but I will, in the end, take you to Tipperary. So let me start. And this is the traditional slide which encompasses most of the features of long QT syndrome. It is, of course, a genetically transmitted disorder. The prevalence is 1 in 2,000, and I'll come back to that in a moment. The disease manifests in young age. As a matter of fact, it may also be responsible for stillbirths and for a number of cases of sudden infant death syndrome when it is not recognized as such. Prolongation of the QT interval on the ECG is, of course, the classic marker. But about 40 years ago, I proposed, and that was not very welcome, the possibility that some patients could have the long QT syndrome and still have a normal or borderline normal QT interval. Eventually, this was proven. Syncope or cardiac arrest, especially during emotional or physical stress, are another typical sign, but we also learned that a number of patients may die during sleep. And we, at one point, realized that this was due to mutations on a specific gene. Very importantly, the last 2 points, which show that there is a very high mortality among symptomatic and untreated patients. And at the same time, there is a very high efficacy of the available therapies. When you put together these last 2 concepts, the high mortality for patients without treatment and the efficacy of therapies, you realize while it is no longer justifiable for patients with the long QT syndrome and with symptoms to remain undiagnosed. I mentioned therapy and sudden death. So let me start by showing you this rather old slide. As you see, it goes back to 1985. At that time, I had been able to accumulate data on 233 patients for all of whom we knew the exact time of the first syncope, which we called time 0. At time 0, the average age of this group was 14 years, teenagers, so clearly a very young population. And what you see here is what happened to those individuals without treatment or with a variety of treatment, not including antiadrenergic therapy. The main point is that within 1 year from the first syncope, more than 20% of these individuals died suddenly. This is the price of the errors in diagnosis. This, conversely, was the mortality for patients treated with beta blockers and or sympathectomy in 1985. But nowadays, this mortality is close to 1%. There are few conditions, with the exception of the introduction of antibiotics in clinical medicine, that the proper therapy has led to such a dramatic change in the prognosis of these patients. This sentence, beta blockers at full blocking dose represent the therapy of choice and are greatly effective in reducing mortality, sounds very familiar to all of you, I'm sure, and everyone agrees. And no one finds anything of interest here. The only point of interest is that this sentence is what I published in 1975, 45 years ago. And I'm glad to see that that statement remains fully valid today. For those of you who want to know more and more details about genetics, electrophysiology, management, and so on, this very recent review that appeared in Nature Reviews a few months ago with leaders in the field, as you see, the co-authors, can provide the necessary information. I mentioned at the outset that the prevalence of long QT syndrome is approximately 1 in 2,000. Now, for all these genetic disorders, when you read in a manuscript or in a review what is their prevalence, well, you need to realize that those information are all guesses. In other words, there are no hard data. There is an exception, and this is indeed the long QT syndrome, because here when we say 1 in 2,000, this is based on actual data. And they come from a rather special study. We analyzed and prospectively studied more than 44,000 newborns with an ECG made between day 15 and 25. Now, the choice of these dates is because in the first 10 days of life, there is an excessive and spurious prolongation of the QT interval, which would lead to many false positives. In our study, we performed the second ECG whenever the first one was showing a QTc greater than 440 milliseconds. And in these, we performed molecular screening that indicates that the prevalence is likely to be very close to 1 in 2,000. In terms of genetics, we now know that there are 17 genes associated with the long QT syndrome, but 3 of them are the most important. And this has affected our terminology. Now, we don't talk anymore about long QT syndrome in general, but we talk about LQT1 if the mutations affect the IKS current, LQT2 if the current affected is IKR, and LQT3 when the mutations affect the sodium current. Now, IKS is, to me, a very important current because I believe it is the one that helps people to understand how tight is the relationship between cellular electrophysiology, ionic currents, and clinical manifestations. IKS is enhanced by catecholamines, becomes the predominant potassium current whenever sympathetic activity increases. Now, mutation on IKS impair QT shortening when heart rate increases. Now, if you start running, your heart rate will go up, your RR interval will shorten, and you desperately need your QT interval to shorten as well. Otherwise, there will be the R-on-T phenomenon, and you will go in ventricular fibrillation and die. So the efficacy of the IKS increase during exercise is essential. Now, if this is true, and then you look at patients with mutations on IKS, when would you expect them to be at risk of dying? Well, if all this that I'm showing you is correct, you would expect them to be at risk during exercise or during emotions. That's a nice hypothesis, but you need to prove it. So what we did was to put together 670 patients of non-genotype, all with cardiac symptoms. As you see, there was a large group of colleagues who participated 20 years ago, exactly. And we looked at the conditions associated with life-threatening events. We also looked at syncope, but this slide is focusing on cardiac arrest and sudden death. So if you look to LQT1 at the beginning, you will see that 90% of these events occur during either exercise or emotion, exactly as predicted by the understanding of what IKS does. Conversely, if you look to LQT3, you see that 80% of them have their events nighttime. So there is a specific situation at risk based on the specific mutations. Now look at these 2 arrows here. I put down these arrows 20 years ago when I was preparing a figure for the paper that I wanted to submit to circulation. And initially I was wondering a little bit, why is it that these 2 groups, one with a mutation on a potassium current and one with a mutation on a sodium current, behave so similarly during exercise? But the explanation was actually very simple. These individuals have a very normal IKS current. So when they run, they are able to shorten their QT. And that is why they are not at high risk during exercise. Personally, I think that is absolutely beautiful because it helps us to understand this tight relationship between ionic currents and what happens at clinical level. And clearly, this has also to guide our approach and management. We also realize that there are specific triggers. For LQT1, for instance, swimming is especially important. If a kid comes to your office with a long QT interval and the parents tell you that he or she fainted while swimming, you can almost bet that this will turn out to be an LQT1. Conversely, auditory stimuli are especially important for LQT2. The alarm clock in the morning, a sudden noise when they are asleep, telephone ringing, these things are typical for LQT2. You may also remember that the first genes for long QT syndrome were identified at the end of March 1995. In December of the same year, we were able to publish the first paper suggesting a gene-specific therapy. Our reasoning was that since in LQT3 patients, the mutation on SCNN5A, which is a sodium current, leads to an increased inward sodium current, probably the old sodium channel blocker mexiletine might have been of help. And indeed, we have found and shown that mexiletine can shorten the QTC by an average of 90 milliseconds in LQT3 patients. And recently, with Mike Ackerman, we found that it shortens a little bit also the one of LQT1 and LQT2. In terms of therapy and diagnosis, again, in the 45, 50 minutes that Carlos has given to me, I can't cover everything. So for diagnosis and therapy, I would suggest you to read this review article that I wrote with Mike Ackerman. In terms of diagnosis, I won't spend time on it, but since 1993, I've been suggesting diagnostic criteria which have evolved in this way. So now we have a score with points. I will not enter in any detail. I don't actually use the score because I see patients every day. But I think that this score could be very useful for those clinicians and cardiologists who seldom see long QT syndrome patients. For them, this score may provide some help in terms of probability of the disease being there. Now let's come to the therapy for long QT syndrome. And in the beginning, there was indeed a great confusion. In Sweden, they would say that is a true smorgasbord. These were the therapies used until 1975. And if you just look here, you will see that almost everything was used. And when everything is being used, is because people have no idea on what to do. Let me read to you this letter by Professor Conor Ward. Some of you will remember that the long QT syndrome without deafness was initially called the Romano-Ward syndrome. And Ward was indeed Professor Conor Ward, working in Dublin. I had been writing letters in those days to everyone who had published a case of long QT syndrome, and this is his answer. Now, let me also point out to the date. We are in July 1972. So I was 29-year-old and pestering everyone in the world, asking what was happening to their patient. Now, let's see his answer, because he says that dear Dr. Schwartz, I enclose copies of 2 short papers on QT syndrome. Unfortunately, the patient was maintained free from attacks on a combination of carbamazepine and phenobarbital for 1 year, subsequently had a single fatal attack. Dürer, as some of you will remember, was a pioneer of electrophysiology in Europe, working in Amsterdam. So he says that Dürer in Amsterdam has been observing another patient. So notice another patient, one patient. And when I last spoke with him, he was pessimistic about controlling the condition in any way. Digoxin shortens the QT, but does not prevent attacks. As a matter of fact, in the initial days, most patients were treated with digitalis and all of them were dying. It may be that the remission we had with phenobarbital and carbamazepine was due to their combined sedative effect rather than any specific cardiac action. And I believe that he was absolutely right. So this was the situation. And let me show you another letter. This was written in 1973, and I wrote to Professor Barlow in Johannesburg. Barlow is the man of the mitral click, so many of you will know his name for other reasons. But he had published a paper in the British Heart Journal on a family with long QT syndrome, and this is the type of letters I was writing around. Dear Dr. Barlow, I'm deeply interested in the long QT syndrome from both clinical and experimental points of view. I would be grateful if you could let me know whether the patient you describe, a British Heart Journal, blah, 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 are still alive, and in the positive case, under which treatment. And here comes vintage Schwartz, because I wrote to him, I'm now following 2 of these patients. So at age 29, 30, with just 2 patients, I thought to be ahead of the entire pack, which I think is incredible. But my friends say that I have not improved at all in the last 50 years. And then I asked to have additional information. So these were the kind of letters that I was sending around everywhere in 1972 and 73. And these eventually constituted the basis for the so-called International Registry of the Long QT Syndrome. It was indeed in 1975 in Houston that I met Arthur Moss, and we met again a few times. And when he saw the number of patients I was dealing with, because in 75 I've already had the data on over 600 patients, he proposed that we do a registry, an international registry for the long QT syndrome, which we launched in 1979. I remember that we discussed about how to implement it during a meeting in Vegas in 1977. And when Arthur Moss asked me, how long should we run this registry? My answer was, let's do it for 25 years. And which now I would not be able to do, of course. But in those days, I thought that we had enough time to plan for a 25 years long study. The objectives were to define the natural history, to define the clinical course, and to assess the efficacy of therapies. These were the initial publications, but the one that I wish to share with you in terms of concept is the one we published together in 2005 when we reached the 25th anniversary of the registry. And there are a few things that Art Moss and I wrote in this article that I wish to share with you because I believe that they carry a special meaning. We joined forces with the goal of unraveling this mysterious disease by establishing a prospective international registry for long QT syndrome. When molecular biology techniques made possible the identification of disease-causing genes and mutations, what became essential was the availability of numerous and well-developed clinical pedigrees, providing clear separation between affected and non-affected individuals. This is what the registry was able to provide, and where it played a decisive role in sharing with molecular biologists the ideal material for their analysis. In 1979, when the registry was established, it did not escape us that this long-term project was likely to contribute to a better understanding and management of long QT syndrome. Quite frankly, however, we did not anticipate the explosion of knowledge that would result from the genetic and molecular findings of the 90s, and the central role that the registry, with its well-defined clinical phenotypes and family pedigrees, would play in uncovering the secrets of this disorder. Let me then come to therapy, where we are now. And I'll start with traditional therapies and move on to the new therapeutic options. So for these four aspects, I will say just a few words. As to beta blockers, I will just remind you that they are not all equal. And it's very clear that propranolol and nadolol are associated with the best results. Metoprolol should not be used because it is associated with a significant number of recurrences. And also atenolol is not working well. So there are really no justifications to use in a long QT syndrome patient any beta blocker different from propranolol or nadolol. Left cardiac sympathetic denervation plays a significant role, and this is something, I mean, Carlos has referred to my autonomic work. The autonomics have been my other part of life in terms of science. And these are the main results, main effects of left cardiac sympathetic denervation. Paramount is the fact that this surgery, which can be performed in about 35 or 45 minutes, reduces the release of norepinephrine at nerve endings. It reduces arrhythmias associated with myocardial ischemia, increases ventricular refractoriness, increases the threshold for ventricular fibrillation, and I will come back to this point, increases myocardial reactive hyperemia, which means that increases the ability of coronary beta to dilate, and there's no negative effects on the cardiac performance during exercise. These data were obtained while I was working in the mid-70s in Galveston, Texas, and they show the effect of striated ganglion block. This was a reversible block by cold on the threshold for ventricular fibrillation. As you see, there is a major increase by 70% in the threshold. And increasing the threshold for ventricular fibrillation means making more difficult for ventricular fibrillation to start. As a matter of fact, in this paper, we concluded by saying that to raise the ventricular fibrillation threshold without drugs in patients at high risk for ventricular fibrillation is a rational approach to the effort of preventing sudden cardiac death. This has become very clear during the past 40 years, and now sympathectomy, primarily the left, but also bilateral when dealing with certain situations like VT or ischemic heart disease, dilated cardiac disease, contributes a lot to prevent sudden death. These were the 2017 guidelines, where left sympathectomy is recommended for high-risk patients with a QTc greater than 500 milliseconds or with syncope despite beta blockers. My view is that to implant an ICD in these patients without trying first left cardiac sympathetic denervation is no longer justifiable. And the other important thing that I wish to say is that the patients should always be offered the possibility of making a choice between the ICD and left cardiac sympathetic denervation. As to the ICDs, the largest study in the long QT syndrome is the one that we published 10 years ago on 233 patients. It's important to note that 25% of them had major adverse events within 5 years. Now, there's no question that the ICD can prevent that, but also quality of life is important. So it's essential that a good cardiologist assesses carefully what are the pros and cons and the risk of a specific patient. We think that is reasonable to use the ICD in survivors of cardiac arrest on therapy, in patients with syncope on beta blockers when sympathectomy is not available, and in patients with syncope on beta blockers who have 2 mutations, especially the Jervell-Langenese syndrome. Mexiletine, I've already mentioned to you. These were the 2 papers that I had mentioned, so I won't spend time on it. But certainly, mexiletine can be very helpful in shortening the QT interval. That's not enough. I mean, these patients certainly need to remain on beta blockers as well. Now let's come to the new therapeutic options. And there is now the possibility of offering the patient gene-specific management. This is on top of the traditional beta blocker or additional therapies. So here we are implementing management based on what we have learned by the understanding of the conditions associated with life-threatening arrhythmias. So LQT1 patients should limit strenuous exercise. Swimming should be allowed, but with supervision. And by supervision, I mean the supervision of an adult who can swim. If the adult cannot swim, it's useless. LQT2 patients are exquisitely sensitive to potassium levels. They should avoid loud noises, alarm clocks, and nighttime telephone in the bedroom. I always, I always tell the parents of these children never to bang on the door in the morning and start yelling, get up, you're late for school. The best way is to give a kiss to their kids in the morning and say, good morning, dear. This is a way to combine good parenting with gene-specific management. Beta blockers for LQT2, we always give them morning and evening, and this is to ensure that the plasma concentration in the morning is adequate, because that is a time of greater risk. For LQT3 patients, there is a possibility of considering having an automatic external defibrillator at home, because that is where most of these patients have troubles, and there is potential value in bedroom sharing, and I can explain that in the discussion time. Let me now come to the last part of my talk. I think we have another 15 minutes probably. And I wish to take you toward precision medicine, because this is, in my opinion, the most fascinating development that one can imagine. And what is precision medicine? Well, in one line, is the opposite of an ICD. And this is not out of disregard for an ICD, it's just that the ICD is not precision medicine. It's does work well, but precision medicine is the opposite thing. Now, precision medicine, in my mind, started with these two papers in Cell, 2006, 2007, by Shinya Yamanaka. And for these two papers, Shinya Yamanaka got the Nobel Award in 2012 for the discovery that mature cells can be reprogrammed to become pluripotent. In essence, the IPS technology is based on the fact that we can now take a blood sample with blood mononuclear cells and differentiate them into cardiomyocytes, the IPS cardiomyocytes. In other words, we can study the cardiac cells of the patients with their exact genetic background. So this is allowing us to do something that was not even thinkable 10 years ago. Before I continue, let me remind you that there are 4 mechanisms by which mutations can have their effect in long QT syndrome. Here we are referring to LQT2 patients and the loss in IKR, in potassium, the rapid potassium current. I would like to focus on class 2 mutations because they disrupt protein trafficking. In other words, they do not allow the protein to reach the membrane. Craig January has shown several years ago that most LQT2 mutations are class 2. They impair trafficking. And even in our own database, 62% of the mutations for which we know the functional effect are due to trafficking mutations. Now, the background for what I'm going to show you is that, as I just said, class 2 mutation in LQT2 are due to trafficking defects. There is this compound called the lumacaftor, we are referring to it as LUM, which is a drug acting on channel trafficking already successfully tested for cystic fibrosis and with a safety profile well known. We generated cell lines of cardiomyocytes from 5 LQT2 patients harboring class 1 and class 2 mutations. we knew that 90% of the mutations underlying cystic fibrosis cause trafficking defect. The therapy for cystic fibrosis is based on this drug lumacaftor, and we wondered whether we could use this strategy for LQT2 mutation caused by trafficking defects. This was a paper which we published in European Heart Journal in 2018, and Craig January wrote a nice editorial saying that in his opinion, this was advancing precision medicine. But what were the conclusions of the study? In a word, lumacaftor shortened repolarization in the iPS cardiomyocyte with class 2 mutations by correcting the hERG trafficking defect. And thereby, the use of lumacaftor in LQT2 patients not protected by beta blockers could become feasible and represent a novel therapeutic option. Well, I'm not used to just do things halfway. If I say that something could be useful clinically, then I test it clinically. And this is what we did, and we published this paper in 2019. So what did we do? We took our two patients whose cardiomyocytes responded to lumacaftor, and we tested whether the commercial association called Orkambi could shorten their QT interval. These are in essence the results for both patients. You see the shortening in QT interval during the 1 week treatment with this drug. And in this case, you see that during the washout, there was a clear rebound that is confirming this effect that was starting already in the first day of treatment. Now, I have to say that the actual shortening was less than what we were hoping for. I've always been thinking that a QTc shortening to be clinically significant should exceed 40 milliseconds. Here we are in the range of 30 milliseconds, but it's going in the right direction. Now we have established a trial, and we're going to study hopefully 20 patients, and we'll be able to assess whether or not this could be an additional therapy. But the principle remains valid, that we could use the cardiomyocytes of the patients to test whether or not novel drugs could be useful. And just a few weeks ago, Mike Ackerman has confirmed our lumacaftor experimental finding in circulation, genomic and precision medicine. Now let me turn toward what in a sense is the last part of my talk. And it all starts with a disturbing clinical question, which we as clinicians face all the time when dealing with these diseases. Why is it that among two siblings with the same disease-causing mutation, one suffers cardiac arrest and the other goes through life without any cardiac event? Well, the answer almost certainly lies in the presence of modifier genes. But if you want to study modifier genes, you need something special. What you need are founder populations. What are founder populations? Well, founder populations are a large group of families all coming from the same ancestor, where you have a large group of individuals sharing exactly the same mutation. Then you can assess whether there are or not modifier genes. If you want to learn more about modifier genes and founder populations, you might be interested in this short editorial by the title Sudden Cardiac Death, Founder Populations and Mushrooms. What is the link with gold mines and modifier genes? Well, the story in our case started in 1690 when a Dutchman left the Netherlands, went to South Africa and settled in Stellenbosch. Dutchmen were doing that because they had the Company of the Indies and they needed to stop to get some oranges and lemons in South Africa, in Cape Town and the Stellenbosch area. So during this guy, this individual had long QT syndrome, type 1. And during the following 300 years, his genes and this mutation called A341V traveled extensively. In partnership with Professor Paul Brink at Stellenbosch University, we identified 25, now they are 26, families descending directly from the Dutchman with long QT syndrome. and all the affected individuals carry the A341V mutation on the KCNQ1 gene. Now, there is a genealogist working at the University of Stellenbosch coming from this family, and he was interested in tracing the family. So here we go, and we went back to the origin of the family. There was this family here, these parents from whom everyone has descended, but look at the father. The father's name is Peter Schwartz. This is my name in Dutch. He married a French Huguenot lady by the name Sarah Louis, and they had all these other people coming down here. And I'm not making it up. When we had to write the first paper, I think it was Dan Roden who said, no, we cannot mention this because the reviewers will not like it. But eventually I decided to tell the truth. So the entire story in South Africa starts with Peter Schwartz. Well, we are now dealing with 500 mutation and non-mutation carriers. 82% of them have syncope or cardiac arrest and sudden death. And I will show you the first slide we made on this paper, on this population. If you look to the right, you see that the non-mutation carriers in the family, they have a very normal QT interval. 440 is the upper limit of normal. Their QTC, I don't know why it disappeared, but this one is 400 milliseconds. But if you look to the left, where we have the mutation carriers, not only you see that most of them have a very long QT interval, but it's all over the places. You would expect if the prolongation of the QTC is made by this same mutation, they should have a sort of narrow prolongation wherever you want, but a narrow one. So this spectrum of values suggested to me that probably there are multiple other factors that modify the effect of the mutation. So this was the beginning of our studies for the identification of modifier genes. I don't have time to enter in all details. We identified 3 modifiers that worsen the situation, one that is actually reducing risk. And those of you interested in modifier genes for sudden cardiac death, then you should look at this review article, which we published just 2 years ago in the European Heart Journal, and which covered the area of modifier genes for sudden cardiac death. I will now come to the last 4 slides or 5 slides in my talk, because here I'm going to show you, I think, probably one of the most exciting findings of my entire long QT syndrome story, trying to understand the mechanism of action of protective modifiers. This was a study carried out in one family. And again, my view is that if your design is careful enough, if you're good enough in doing research, from one single family, you can extract a lot of information. In this family, there was a kid with cardiac arrest. His father, uncle, and aunt had the same identical mutation, but they had a completely normal or almost normal QT and no symptoms throughout their life. So we plan to study the symptomatic son and the asymptomatic father. We developed the IPS for the cardiomyocytes. Then we did a cellular study. If you look to the symptomatic kid, you see that his action potential was clearly much, much longer. But the father, his action potential was essentially normal. When we look to the IKS current, again, the symptomatic kid had almost no IKS current. The father had just a minimal loss, almost normal. Well, this was explaining why they were being different, but we didn't know why they were different. So if you look here, you see that both the symptomatic son, the asymptomatic father had the same disease-causing mutation, producing LQT1 through one of these 4 mechanisms, actually trafficking. But the father, as well as the uncle and the aunt without symptoms, also had in his DNA a counteracting mechanism. This mechanism was interfering with the mechanism of action of the mutation, and by doing that was preventing the ion channel function alteration and leading to no cardiac events. Now, what I'm going to show you in the next slide is that we have uncovered the exact mechanism. So I need a little bit of attention from you here, because it's never easy to translate this type of knowledge in slides and in easy concept. Let's start from wild type. This is a normal individual. When we use WT, wild type means a normal individual. A normal individual would have normal KCNQ1, which is a gene for IKS, normal KCNH2, which is the gene for IKR, and a normal MTMR4, which is a different gene, which is important because when it's normal, there is a normal process called ubiquitin-mediated potassium channel degradation. This is a normal phenomenon that degrades potassium channel before it reaches the membrane, and is a normal phenomenon. Now, if we look here to the symptomatic kid, he has this mutation which reduces IKS. He has a normal KCNH2, he has a normal MTMR4, and thereby this effect, which has no counter mechanism, produces a very long QT interval and is clinical manifestation. What about the father, the asymptomatic father? He has the same mutation like his son. His IKS is decreased. He has a normal KCNH2 like his son, but he has a mutation on MTMR4. And what does this mutation do? This is diminishing the potassium channel degradation throughout another protein, which I will not discuss now, called MED, but the essence is that this mutation reduces the potassium channel degradation. Why is this important? Because the consequence of this is that there is an increase in IKR. So by reducing the potassium channel degradation, the IKR current comes to the membrane. So here you have this almost normal situation of a QT that is not completely normal, but almost, and no symptoms. This is the first time we've been able to identify the mechanism of action of these protective genes. So now in the practically final slides, we identified additional 13 patients that carried the same mutation present in that family. There were 3 of them with a wild type MTMR4, like the symptomatic kid, and they all have a very long QT interval. 10 individuals have these mutations, these protective mutations, and as you see, their QT interval is very modestly prolonged. Now, this was the paper. We published this paper this year in Cardiovascular Research. It's a complex paper, but here you will find the entire story. And the conclusion at this point is that some individuals inherit a long QT syndrome causing mutation. The same individuals may inherit certain genetic variants capable of specifically interfering with the mechanism by which the mutation alters the phenotype. The genetic transmission of the two is independent, obviously, and so the coexistence of the two is a play of chance. But if present, the result could be a decrease in arrhythmic risk. And the last slide I wish to share with you is a paper that was published just last week in the European Heart of Journal, where I've had the privilege of being able to narrate the story of my own research lasting 50 years on the long QT syndrome. And as some of the letters that I showed to you at the beginning were written while I was not yet a specialist in cardiology, I was really a rookie. I hope that this paper and talk may be a stimulus for the young investigators sitting in the audience. Thank you for your attention, and thank you, Carlos, for the privilege of being with you in Calgary today.
Thank you, Peter. That was a fantastic overview of a lifelong search on the long QT syndrome. Thank you very much. We got a lot of people here that know a lot about this disease. So Hank, any questions or comments? You got to unmute yourself.
So yeah, beautiful talk. I enjoyed it very much, and
Thank you.
I really appreciated the idea that with small kindreds that are very well studied, that you can actually learn a lot. So I really appreciated it. Thank you.
Pleasure. What can I say? I agree. We both agree.
So when you were giving the lecture, I was wondering if you had already figured out what was the counteracting mechanism, and I guess you already did. But this is only for LQT2. What about LQT1 and LQT3?
Well, that is what we're working on. I mean, we identified other modifiers, as I have listed in one of my slides. We still don't know the exact mechanism by which they work. And this is where my research is focusing now, trying to uncover the mechanism of action, because I don't think it's only of intellectual importance, but if we understand, like in this case, what a protective mutation does, we could, in theory at least, develop a molecule mimicking the effect of the modifier, and that could have therapeutic value. So I think we are entering in a completely new game here. I mean, that is why I think that the use of iPS cardiomyocytes can really produce a revolution, because now we have tools that were beyond imagination a few years ago. And again, it will take time. I mean, it took me 50 years to get here. It will take me another 50 years to continue. I mean, so I need some time.
You did show in those two cases that you were a little bit disappointed on the amount of shortening of the QT. So what do you think are the other factors that are playing a role there?
Well, you know, first of all, the cardiomyocytes that you study are more resembling fetal cardiomyocytes. Their structure is simpler. In a whole heart, there are many greater complexities. So it's not unexpected that moving from a cardiac cell to an entire heart, you find some differences, which can be quantitative. I would not expect qualitative differences, but from a quantitative point of view, you may find some differences. Now, again, with two patients, I would not draw any conclusion. The idea is, I mean, our interpretation was that the results were going in the same direction. They were not as evident. I didn't show a very clear picture looking at the Holter recordings in our two patients during that study, because it was clear that most of the time during the drug study, their QT interval was significantly shorter than in baseline. But again, we needed to increase the numbers. Carlos, there are no shortcuts in medicine. I mean, if you want to do something seriously, you've got, yes, you make the observation on a small number. I'm grateful for the comment received before about the importance of small kindreds. But then once you've made an observation in a small family or in a single case, you've got to convince the rest of the world, and then you need to go to large numbers. So I use small kindreds or a clear model to get an idea, but then you have to validate it, and that takes time.
Yeah. So here's a couple of questions. One from Russell Quinn, who's one of our electrophysiologists. He's asking that for long QT syndrome 1 patients with events while swimming, when do the events tend to happen? Is it with the initial immersion, maybe the diving reflex, or is it the exercise itself, breath holding, or some other factor? Does water temperature have an effect? What is the main physiology which provokes the event?
Okay, that's a very good question. I don't think as anyone reported on that's occurring immediately during diving. Diving is important, of course, because then you have a simultaneous vagal and sympathetic activation with increased dishomogeneity of repolarization, but it may take a little while to take place. I mean, so I would expect that if this plays a role, people would dive and then swim for a little while before having the events. I mean, the usual narrative is of individuals swimming and then going down and drowning. Certainly cold water plays a role because cold water increases sympathetic activity. So it's really the combination of cold exercise. Keep in mind, I mean, if I can make an analogy, in all our patients, I mean, all my patients come to see me once every year. I mean, we have and every time we do a 12-lead Holter recording, an exercise stress test, and the usual, the ECG and the visit. On the treadmill, when they run or on the bike, they almost never, I mean, I would say never have any cardiac arrhythmias. And this is probably because exercise performed in the hospital setting is just exercise, nothing more than that. There are no emotions involved. This is a situation different from CPVT, of course. But if you think about little children, children age 4 or 5, the very risky moment in terms of activities when they play hide and seek. We have all played hide and seek, and I think we all remember that it was not only running, it was running with the fear of being discovered. So it's running with an emotion. So it's really, in my opinion, the combination of physical and mental stress that is more arrhythmogenic than just sheer exercise. Unproven. I mean, that's my idea.
Great. So there's another question here with respect to the difference in efficacy between propranolol, nadolol, and metoprolol. Is it simply related to the use of shorter acting metoprolol tartrate as opposed to metoprolol succinate, which is longer acting?
We don't know. And I like to say we don't know often because that's a straight answer. What we have is enough experience and enough data to say that both nadolol and propranolol are effective. Nadolol has also some sodium blocking activity that we have described in the past, not as much as propranolol, but it has them. The fact is that the results are very clear. We have a large number of the stories of patients who were doing well on nadolol. Then nadolol at one point became difficult to find. They were switched to metoprolol and then developed cardiac arrest. And this is, has occurred all over the world. So at one point, as a practicing physician, my point of view is, if I can understand the mechanism, fine. If I don't understand the mechanism, I look at reality. If the reality tells me that patients do well on nadolol and on propranolol, and many of them have recurrences on metoprolol, I would not give them metoprolol. Sometimes you have to accept that knowledge is incomplete. There have been some explanations put forward for the failures with metoprolol, but the fact is that it fails, and it fails too often. And I cannot risk the life of my patients just to try something else. If I have a safe therapy, I would stick to that.
Well, thanks, Peter. That was fantastic. It's 9 o'clock, and again, it was a beautiful lecture. Learned a lot, and it's 50 years of your life work. So thank you very much for sharing that with us. I do recommend to people to read your paper in the European Heart Journal. I read it, and it was a beautiful paper. So you take care. Hopefully we can get you here to Calgary sometime next year when this
Thank you. Looking forward. Thank you, Carlos. Goodbye, everyone. Thank you.
Take care.